Hello, I am Dr. David Sugarman, lead for the Measles, Rubella, and Cytomegalovirus team for the National Center for Immunization and Respiratory Diseases, NCIRD, at the Centers for Disease Control and Prevention, CDC. I will be the moderator for this session, and I am delighted that you are participating in the 2025 CDC Training for Vaccine-Preventable Disease Surveillance. This 2025 course is presented in two sessions. In this session, we will cover viral vaccine-preventable diseases, or VPDs. The bacterial VPDs will be covered in a separate session. For those seeking continuing education credits, please follow the directions at the end of this session. You must register on CDC Train to receive continuing education credits for this course. CDC, our planners, and content experts wish to disclose they have no financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept financial or in-kind support from any ineligible companies for this continuing education activity. In this session, we will cover mumps, measles, rubella, rotavirus, varicella, acute flaccid myelitis, and polio. In addition, we'll discuss surveillance needs at the various levels of public health, the Manual for the Surveillance of Vaccine-Preventable Diseases, which includes many disease-specific and cross-cutting chapters, will serve as the text for this course. Throughout this session, subject matter experts may make reference to specific chapters or appendices found in the manual. The 7 objectives for this course are to identify the 3 main levels of the National Surveillance System for Vaccine-Preventable Diseases, discuss the importance of case identification for surveillance, describe appropriate mechanisms for surveillance, describe the appropriate application of case definitions, including clinical description and case classification, list the most appropriate laboratory tests for surveillance, list epidemiologically important data to collect for surveillance, and describe one way this educational activity will improve contribution as a team member. At this time, we will begin our discussion of mumps, presented by Dr. Sarah Oliver. Dr. Oliver is the team lead for the mumps, varicella, and zoster team in the Division of Viral Diseases in the National Center for Immunization and Respiratory Diseases at the Centers for Disease Control and Prevention.
Thank you, Dr. Sugarman. I appreciate this opportunity to discuss the important aspects related to mumps surveillance in this session. Mumps is an acute viral illness caused by a paramyxovirus. Mumps typically presents as unilateral or bilateral parotitis, which is a tender, self-limited swelling of the parotid or other salivary gland, lasting 2 or more days. While parotitis can be due to infectious and non-infectious causes, mumps virus is one of the only causes of outbreaks of parotitis. So if you see a couple of cases of parotitis, think mumps. It's also possible to be infected with mumps and present only with non-specific respiratory symptoms or to be asymptomatic. Mumps infections may be asymptomatic in about 1/5 of unvaccinated persons. There is little evidence available to show how frequent asymptomatic infection occurs among vaccinated populations. The most common complications are shown in this table on the right and include orchitis or swelling of the testicles, oophouritis, or swelling of the ovaries, mastitis, pancreatitis, hearing loss, meningitis, and encephalitis. Complications are more frequent in adults than children, and complications are less frequent among vaccinated patients. As many as 30% of unvaccinated and 6% of vaccinated post-pubertal males with mumps will develop orchitis. While there's a theoretical risk for sterility, given men with orchitis can develop testicular atrophy, low sperm count, or reduced sperm mobility, no studies have assessed the risk for infertility among men with mumps orchitis. Mumps is transmitted by droplet secretions and requires close contact to spread from person to person. Studies show that people are most contagious 2 days before until 5 days after parotitis onset, but those with non-specific respiratory symptoms or asymptomatic infections can also transmit disease. The mumps incubation period is long, ranging from 12 to 25 days, with an average of 16 to 18 days contributing to prolonged outbreaks. An outbreak is defined as 3 or more cases of mumps linked by both time and space. The mumps vaccine is a component of the combined measles, mumps, and rubella, or MMR vaccine. In 1977, the Advisory Committee on Immunization Practices, or ACIP, recommended 1 dose of MMR. ACIP recommended a second dose in 1989 due to measles cases occurring among school-aged children who had received 1 dose of MMR. The second dose led to a 99% decrease in the number of reported mumps cases. In 2006, ACIP made an official recommendation for a second dose of MMR vaccine for school-aged children and adults at high risk for mumps. Vaccine effectiveness for mumps is estimated to be 72% for 1 dose and 86% for 2 doses, with wide ranges. Certain factors may decrease vaccine effectiveness and promote transmission of mumps, including being in crowded or very close contact settings, such as schools, or any behavior that involve the sharing of intimate airspace or the exchange of oral secretions. This graph shows the number of reported mumps cases in the U.S. by year from the late 1960s through present. Prior to the introduction of the mumps vaccine in the U.S., mumps was considered a universal childhood disease, with over 100,000 cases reported each year. You can see the dramatic impact of MMR on incident mumps cases. However, since 2006, there has been an increase in the number of mumps cases reported, with several peak years. Since then, outbreaks have continued to occur, mostly in close contact settings among highly vaccinated populations. There have been very few cases of mumps since the onset of the COVID-19 pandemic. Outbreaks have occurred in a variety of settings and geographies. In 2006, there was a multi-state mumps outbreak among Midwest college-age students across many campuses. In 2009 to 2010, there were 2 large outbreaks, one in a close-knit community in New York City, and the second among school-aged children in Guam. In 2016 to 2017, health departments reported 150 outbreaks with more than 9,200 cases in a variety of settings, including schools, athletics, church groups, and workplaces. From 2018 to 2019, there were nearly 900 mumps cases reported by 19 health departments associated with migrant detention facilities. These outbreaks among fully vaccinated persons prompted ACIP in October of 2017 to recommend a 3rd dose of MMR during mumps outbreaks for persons that public health deemed to be at increased risk of mumps. In June 2023, the Council of State and Territorial Epidemiologists, or CSTE, approved a new case definition for mumps. The revised case definition sought to improve the capture of the true burden of mumps and increase characterization of the full spectrum of illness, including atypical presentations. This was achieved by removing the 2-day duration for peritidis for epidemiologically linked cases and including all lab-confirmed mumps cases, regardless of clinical presentation. Additionally, the revisions have sought to address the high volume of positive IgM results often performed for low suspect cases. Asymptomatic persons with a positive IgM alone no longer meet the suspect case criteria. The new definition encourages PCR confirmation as well as testing for other etiologies that might cause peritidis. Laboratory testing of specimens from suspected mumps patients can be helpful to confirm mumps. Specimens with a positive RT-PCR result are classified as confirmed. PCR is the preferred test to confirm mumps infection, and buccal swabs are the ideal specimen. But in patients presenting with complications, a urine specimen may be useful to collect as well. Successful detection of mumps virus from buccal swabs is dependent on timing, technique, and the appropriate storage and shipment of specimens. Swabs should be collected as soon as mumps is suspected. PCR for mumps has the greatest sensitivity when the specimen has been collected within 3 days of peritidis onset, but can be performed within 10 days after peritidis onset. If it's been at least 3 days since peritidis onset, it's also recommended to collect a blood specimen for mumps-specific IgM testing. Finally, IgG tests for mumps are used for evidence of immunity, not to assess acute infection. While seroconversion, or a four-fold rise in IgG titer, is indicative of mumps infection, previously vaccinated people are often IgG positive and can have an elevated titer at the time of symptom onset, making IgG less informative. I want to highlight one of our new resources on the CDC mumps webpage, which describes appropriate testing and case classification. This is a flow diagram for what testing to conduct when a patient arrives with symptoms consistent with mumps. This tool also highlights that parainfluenza viruses 1, 2, and 3, Epstein-Barr virus, influenza, adenovirus, and human herpes virus 6 can interfere with mumps serologic assay and cause false positive results and themselves cause parotitis, furthering the importance of collecting buccal specimens for PCR. In summary, there have been few mumps cases reported since the onset of the COVID-19 pandemic. However, large mumps outbreaks in the U.S. have occurred between 2006 and 2019, primarily in young, fully vaccinated adults. These outbreaks were characterized by settings with intense, close contact exposures, such as college campuses and immigrant detention facilities. In response to outbreaks among fully vaccinated persons, ACIP recommended a third dose of MMR during outbreaks among groups deemed to be at increased risk. Given the new CSTE case definition and overall low case counts, laboratory confirmation of mumps is very important, and RT-PCR testing with a buccal swab is the preferred way to confirm mumps in a suspect patient.
Thank you, Dr. Oliver. This concludes the mumps section of the training. At this time, we will be joined remotely by Dr. Dan Filardo to discuss measles. Dr. Filardo is an epidemiologist in the Division of Viral Diseases in the National Center for Immunization and Respiratory Diseases at CDC.
Thank you, Dr. Sugarman. I appreciate the opportunity to discuss measles during this training. Measles is an acute febrile rash illness caused by measles virus. It is transmitted by direct contact with infectious droplets and can also be spread by the airborne route. Measles is highly contagious. 90% of susceptible household contacts will develop illness if exposed to a measles case. The estimated reproductive number, or R0, is 12 to 16 in an unvaccinated population, meaning that a measles case would be expected to result in 12 to 16 secondary cases if all contacts were unvaccinated. Since 2001, all but 2 U.S. jurisdictions have reported at least one measles case. Measles was declared eliminated in the U.S. in the year 2000. And elimination means that there has not been any sustained transmission of measles within the U.S. lasting 12 months or more during this time. During 2001 to 2023, we've seen a median of 72 measles cases reported each year. Case counts have generally remained low, below 200, except in years when large outbreaks occurred, including 2014, 2018, and 2019. We've also seen an increase in measles activity during 2024, with 2 outbreaks of more than 50 cases as of November 2024, and consistent importation of measles during 2024, with importations being detected during most weeks. This is aligned with growing measles activity globally during 2024, compared with 2020 to 2023. National vaccination coverage also shows concerning trends, with 2-dose measles, mumps, rubella, or MMR coverage by kindergarten entry dropping nationally from 95% before the COVID pandemic to now less than 93% in the most recent data. While this absolute percentage drop is small, nationally this 92.7% coverage means that over 250,000 kindergartners are at risk for measles each year. Also, in the most recent data, 14 states reported 2-dose MMR coverage of less than 90%, and a total of 14 states reported exemption rates for 1 or more routine childhood vaccination of greater than 5%, meaning that they could not reach the 95% target for coverage even if all non-exempt children received MMR. Measles presents with a high fever, which can be up to 105 degrees Fahrenheit or 40.5 degrees Celsius, and rash, and one of the 3 Cs, which includes cough, coryza, or runny nose, or conjunctivitis, or some combination of the 3 Cs. The rash typically begins on the head, face, or at the hairline, and then progresses downwards to involve the chest, abdomen, arms, and legs. According to the Council of State and Territorial Epidemiologists, or CSTE, case definition, fever, rash, and one of the three Cs must be present to be considered a clinical measles case. Timeline is a very important piece of the history of illness to obtain when suspecting measles. Let's review the typical timeline one would expect. After exposure to the measles virus, there is an incubation period during which time the exposed person is asymptomatic. Around 2 to 4 days before onset of the rash, the prodromal symptoms begin. This includes fever and at least one of the three Cs. Following these prodromal symptoms, the rash begins. The date of rash onset is considered day 0 in a measles investigation, and a person with measles is considered infectious to others from 4 days before to 4 days after rash onset. On average, the time from exposure to developing the rash is 10 to 14 days, with a range of 7 to 21 days from exposure to rash onset. Ideally, reverse transcriptase polymerase chain reaction, or RT-PCR, on a nasopharyngeal or oropharyngeal swab or urine should be performed alongside serology, or IgM, for all suspect measles cases. It's important to note that using IgM alone to test patients with a low pretest probability of having measles will lead to more false positive than true positive results. RT-PCR is available in most state laboratories, at the VPD reference centers, and the CDC. Some commercial laboratories offer standalone measles RT-PCR or inclusion of measles in panel-based testing. However, CDC recommends that providers coordinate measles testing through their state or local public health agency. All RT-PCR positive specimens should be directed to a VPD reference center or CDC for genotyping. A link to the VPD reference centers is at the bottom of the slide. CDC epidemiology and laboratory teams are available for consultation to help with measles diagnosis if needed. A key part of measles investigations is to identify cases, establish the diagnosis, and gather some key pieces of information. This includes gathering the clinical and laboratory data to understand if the case is confirmed and by what method, gather a detailed vaccination history, including all doses of measles-containing vaccines and dates of administration. In the US, measles vaccination is included only as part of MMR or MMRV vaccine, which includes varicella, but globally, MR, that is measles rubella, and measles-only vaccines are used as well. Finally, gathering information about measles exposures in the 21 days before rash onset is important, including international travel or exposure to known measles cases. If a confirmed measles case has no travel or known exposure in the 21 days before rash onset, it's important to consider places where they might have been exposed to an unknown measles case. This includes school, childcare facilities, places where they may have been exposed to international travelers, including domestic or international airports, tourist locations, or finally, healthcare facilities. As we discussed, the average time from exposure to rash onset is 10 to 14 days. So for example, a visit to a busy emergency room 14 days before rash onset would be concerning for possible exposure at that healthcare setting and may warrant further investigation. Contact management involves identifying all locations where measles exposures may have occurred during the infectious period of the confirmed case, that is, 4 days before to 4 days after rash onset. Investigators should identify and prioritize susceptible contacts, especially those with close contact, including households or daycare and school classrooms, for monitoring or other interventions, including post-exposure prophylaxis or PEP. Exposed persons at higher risk of severe disease who may require PEP include infants less than 1 year of age, pregnant women, and people with immunocompromising conditions. Finally, quarantine or exclusion from high-risk settings may be warranted for exposed contacts without evidence of immunity. 2 options are available for PEP for measles: MMR vaccination or immunoglobulin. PEP with either MMR or immunoglobulin given within the target window, which is different for these 2 options, may provide protection from developing measles, or if it doesn't fully prevent measles, may modify the clinical course of disease and protect against severe complications. MMR should be given within 72 hours or 3 days of the initial measles exposure to be effective. Vaccination can be given after this window, but would only be expected to protect from future exposures. Immunoglobulin should be given within 6 days of exposure to be effective. Immunoglobulin can be given intramuscularly or intravenously. Intravenous immunoglobulin should be prioritized for adults who are at high risk of severe disease, primarily pregnant women or people with immunocompromising conditions, because intramuscular immunoglobulin may underdose people weighing over 30 kilograms. Immunoglobulin is also the only post-exposure prophylaxis available to groups that cannot get MMR vaccination, including infants under 6 months of age, pregnant women, and people with immunocompromising conditions. As we know, vaccination is the best prevention for measles. I won't go into depth here on routine vaccination, but here we can discuss a few scenarios that differ from routine vaccination recommendations, which are for 2 total doses by the time of school entry. Preventing measles in the US includes preventing measles among international travelers, and the recommendations differ a little bit from the routine for international travelers. For infants 6 to 11 months of age traveling internationally, CDC recommends 1 dose of MMR prior to departure. For everyone aged 12 months or older, including children and adults, 2 doses of MMR are recommended prior to departure. As a reminder, all MMR doses must be separated by 28 days. Additionally, for an infant vaccinated at age 6 to 11 months, this is sometimes called a 0 dose, as it doesn't count towards the 2 routine doses, and 2 more doses should be provided according to the routine schedule. For outbreak control, there are some additional considerations. If preschool-age children are at risk due to the outbreak location and transmission settings, a second dose early between age 1 and 4 years could be considered, and adults in educational or childcare settings could be considered for a second dose at least 28 days after a prior dose. If infants less than 12 months of age are at risk due to the particular characteristics of the outbreak, consider vaccination of infants 6 to 11 months of age who are at risk of measles due to the outbreak.
Thank you, Dr. Filardo. At this time, we will review a measles case study presented by the New York City Department of Health and Mental Hygiene. The presenters will be joining us remotely and include Chloe Peters, a public health epidemiologist, Beth Isaac, a city research scientist, and Larissa Gutierrez, a public health epidemiologist and immunization surveillance supervisor.
Thank you, Dr. Sugarman. We are going to present on a measles case we had in New York City earlier this year. We received a call from a medical provider at a hospital regarding a patient with suspected measles on March 22nd, a Friday afternoon around noon. We were told that the patient is a 10-month-old infant with a fever of 102.4, a rash that started on the head and face and moved down to the chest, abdomen, and extremities, and cough and runny nose. The infant returned from Pakistan 1 week ago, visiting there for 1 month. The infant came to the ED before March 21st and was admitted early that morning. We were very concerned that this might be a measles because this was an unvaccinated child with recent international travel with measles compatible symptoms, fever, rash, and 1 or more of the C's. The infant rash onset was on March 18th. Because the infectious period begins 4 days before rash onset and lasts for 4 days after rash onset, the infectious period would have started on March 14th and would have ended through March 22nd. I called the infection control department at the ED to verify that the infant was placed in a negative pressure airborne isolation room and find out if there were any exposures before the infant was placed in this type of room. The staff relayed that the patient was not placed in airborne isolation immediately, so there were exposures in the hospital ED during the prior night. They let us know that the infant was also seen at the hospital outpatient clinic 2 days prior on March 20th and at a different ED earlier in the week on March 18th, all during their infectious period. So in total, there were 3 healthcare settings with potential exposures. I assigned a case investigator to interview the family immediately to find out if the infant went to any other places during their infectious period. The family informed us that their flight from Pakistan back to the US was on March 15 during the child's infectious period. We advised the provider to collect an empty swab for measles PCR testing and blood for serology and arrange for a specimen to be tested at our DOH public health lab.
In New York City, were able to use our citywide immunization registry to find siblings and ascertain their measles immunity status. I found records for a sibling and the infant's parents who fortunately had one or more documented MMR doses. The infant also spent time with an uncle who had 2 documented MMRs and their grandparents who unfortunately did not have documentation of measles immunity and were born after 1957. The grandparents were past the MMR vaccine post-exposure prophylaxis or PEP window. MMR vaccine PEP needs to be given within 72 hours of initial exposure, and the grandparents had been exposed starting 8 days ago at the beginning of the infant's infectious period. The grandparents would need to quarantine until we received titer results that documented their immunity. Because this was a high suspicion case, given international travel and clinically compatible symptoms, our team reached out to either the medical director or infection control team at all 3 healthcare settings with measles confirmation still pending to relay that this infant was seen at their facilities while potentially infectious with measles. We reviewed our guidelines with them and informed them that they need to identify staff, patients, and visitors that were potentially exposed at their facility during the time the infant arrived through 2 hours after the infant left the facility or was isolated in a negative pressure room. We requested that the facility compile a list of exposed patients documenting their age, measles immunity status, pregnancy status, and any immunocompromising conditions. If the exposure at the facility was within the past 72 hours, the facility was asked to recall patients who did not have documentation of measles immunity so that they could receive MMR vaccine PEP, prioritizing children. We also reviewed criteria for immunoglobulin PEP, which we recommended be administered to the following: children under 1 year of age and either too young to receive MMR PEP or beyond the MMR PEP window, women who were pregnant without evidence of measles immunity, or anyone severely immunocompromised, to be given within 6 days of initial exposure. All facilities were within the 6-day post-exposure window for immunoglobulin PEP.
We sent these healthcare settings an email template reiterating guidance provided over the phone. The template included instructions to immediately identify persons and information on measles post-exposure prophylaxis. We also provided a script for reaching out to exposed persons, exposure letters in English and Spanish, a reference table summarizing PEP indications, and an Excel template to help facilities organize their list of exposed persons.
The measles specimens reached our public health lab around 5 p.m. that Friday afternoon, and our public health lab colleagues stayed late to run the PCR analysis. Our lab colleagues called our unit chief around 9 p.m. that night when the results returned and relayed that the PCR was positive, confirming the infant's measles diagnosis. Our unit chief reached out to the infection control and medical director contacts at the 3 different healthcare facilities, relaying these results that night and instructed them to proceed with notifying exposed persons and recalling for PEP if indicated. Our public health lab colleagues forwarded this specimen to the New York State Reference Lab the following week for genotyping. We also notified CDC about the confirmed case the same evening. During the following week, we checked in with the healthcare facilities on their progress with notifying contacts on their success with recalling patients for PEP before the PEP window closed. Once the healthcare facilities had notified as many persons exposed at their facility as they could and completed the Excel template, we requested the list to be securely sent to the health department via REDCap. The list of exposed persons was then reviewed, cleaned, and imported into our database, Maven.
From this one confirmed measles case, there were 281 people potentially exposed at the healthcare facility. Any exposed persons that were not reached and/or that needed to quarantine were assigned to our public health advisors for follow-up. Several of these contacts lived outside of New York City and were transferred to their jurisdiction of residence for follow-up. After the case was confirmed, we notified CDC Quarantine Port Health Station, where the flight with the infant had landed while infectious. Port Health investigated the flight exposure and later provided a list of 8 exposed New York City resident passengers via FAX notification. These contacts were also imported into our database and assigned to our public health advisors for notification and to assess if they developed any symptoms. In total, there were 295 exposed contacts, including household members, healthcare contacts, and flight passengers. Fortunately, there were no secondary cases as a result of these exposures, but this case and their subsequent exposures demonstrates that responding to a measles case is very time and resource intensive, requiring collaboration between healthcare, local and state health departments, and the CDC.
Thank you to our partners in New York City for sharing their measles experience. We will now begin with rubella. Rubella will be presented by Kelly Rains. Ms. Rains is an epidemiologist and surveillance officer in the Division of Viral Diseases in the National Center for Immunization and Respiratory Diseases at CDC.
Thank you, Dr. Sugarman. I appreciate the opportunity to discuss the surveillance of rubella. Rubella is an acute febrile rash illness, often referred to as German measles. Typically, rubella is a mild illness with up to half of all infections being asymptomatic. The average incubation period of rubella virus is 17 days, with a range of 12 to 23 days. For those who are symptomatic, prodromal symptoms can present 1 to 5 days before rash onset and can include low-grade fever, headache, mild pink eye, general discomfort, swollen and large lymph nodes, cough, and runny nose. People infected with rubella are most contagious when the rash is erupting, but they can't be contagious from 7 days before to 7 days after the rash appears. The surveillance clinical definition for rubella, as approved by the Council of State and Territorial Epidemiologists, includes the following criteria. In the absence of a more likely diagnosis, acute onset of a generalized maculopapular rash, fever, and the presence of at least one of the following: arthralgia, arthritis, cervical lymphadenopathy, or conjunctivitis. Rubella can lead to complications and death. Arthralgia or arthritis may occur in up to 70% of adult women with rubella. Rare complications include thrombocytopenic purpura and encephalitis. When rubella infection occurs during pregnancy, especially during the first trimester, serious consequences can result. These include miscarriages, fetal deaths or stillbirths, or severe birth defects known as congenital rubella syndrome, or CRS. Following implementation of the rubella vaccination program in 1969, reported cases declined dramatically, and endemic rubella transmission was declared eliminated in the U.S. in 2004. Elimination is defined as the absence of endemic transmission in a region for 12 or more months in the presence of a well-performing surveillance system. Since then, a total of 152 rubella cases have been reported, with an annual median of 7 cases. 2 outbreaks, each consisting of 3 cases, occurred in 2005 and 2007. Since 2004, only 17 cases of CRS have been documented. Global progress towards rubella elimination has accelerated, with rubella cases declining by 81% between 2012 and 2022. However, rubella is still endemic in many parts of the world, and while incidence in the U.S. is low, importations could lead to subsequent transmission in the U.S. The National Health and Nutrition Examination Survey, or NHANES, was assessed to evaluate seroprevalence of antibodies for measles, mumps, rubella, and varicella in the U.S. population aged 6 to 49 years during 2009 to 2010. The rubella seroprevalence was notably high at 95.3%, reflecting robust vaccine coverage. We anticipate receiving seroprevalence data from NHANES for 2017 through 2020 soon. We will allow us to reevaluate the seroprevalence of these 4 viruses in the U.S. population. It is important to note that 2-dose MMR coverage by kindergarten entry dropped nationally from 95% before the COVID-19 pandemic to 93% afterwards. Overall, rubella vaccination coverage remains high in the United States, but even small geographic pockets of non or under vaccination can predispose a community to rubella cases and outbreaks. Sustained high vaccine coverage plus sensitive and timely investigations with thorough public health response are essential for limiting transmission. Clinical diagnosis of rubella virus is unreliable. Laboratory testing is needed for diagnosis. As presented earlier, up to half of all infections may be subclinical or inapparent, and the rubella rash resembles many other rash illnesses. Therefore, every suspected case of rubella should have molecular and serological specimens collected for testing. Use of both testing methods provides additional confidence in results, potentially limiting false positive results due to cross-reactivity and false negative results due to timing of testing. Public health jurisdictions have reported that IgM testing for rubella is often done inappropriately at commercial labs. This testing is frequently ordered when the goal is to determine immunity. But it's important to note that only IgG should be used for this purpose. In low incidence settings, false positive IgM results are quite likely and can indicate cross-reactivity rather than actual infection. These false positives can lead to inappropriate diagnosis and management, as well as unnecessary public health investigations. The CDC is collaborating with several partners, such as American Public Health Laboratories and Electronic Health Records Systems, to limit inappropriate IgM testing. But CDC cannot regulate the testing protocols of commercial labs. To increase specificity in the reporting and classification criteria for rubella, while maintaining high sensitivity, the case definition for rubella was updated at the June 2024 CST conference. This training will provide a summary of the major updates to the case classification criteria for rubella. A full account of the updates to the rubella case definition can be found on the CST website, linked on this slide. The suspect case definition has been removed from the case classification criteria, and the probable case definition has been revised. Now, probable cases are defined as those that meet clinical criteria, have an IgM positive result, and lack presumptive evidence of immunity. These probable cases lack epidemiologic suspicion, such as international travel or known exposure to rubella or CRS. This distinction is especially important in elimination settings where the rubella virus is not actively circulating. Importantly, for IgM positive results in the probable and confirmed classifications, acquired rubella must be suspected. Tests conducted as a part of routine screening, such as titers for pregnancy screening or employment documentation, should not be included in these classifications. Updates to the definition of confirmed rubella classification now stipulate that all IgM positive results must be supported by additional laboratory evidence, such as a low avidity result, or by epidemiological risk factors, including known exposure or international travel during the incubation period. Additionally, a woman who has given birth to an infant with confirmed congenital rubella may be classified as a confirmed case, provided they meet the residency requirements. All suspected cases of rubella should be immediately investigated to establish a diagnosis, identify the source of infection, prioritize exposure contacts, and implement control measures when necessary. In the rubella post-elimination era, a single reported case is considered a public health priority that requires rapid and appropriate public health response. Since rubella is an infectious disease for which up to 50% of cases are asymptomatic, any investigation of an apparently isolated case could reveal additional cases. Therefore, health agencies should consider a single case of rubella as a potential outbreak. In addition to standard precautions, droplet precautions are recommended during a rubella patient's infectious period. During case investigations, all potential contacts should be identified, and those with higher risk of severe disease, such as pregnant women, infants younger than 1 year of age, people with immunocompromising conditions should be prioritized for care and monitoring. Quarantine or exclusion of contacts from high-risk settings, including daycares or schools and healthcare facilities, may be warranted for exposed contacts without evidence of immunity. Post-exposure prophylaxis is not recommended for rubella contacts. Due to the potential severity of outcomes for pregnant women, it is essential that those who are exposed are identified, evaluated, and counseled. Exposed pregnant women should be tested for the presence of rubella IgG and IgM antibodies, regardless of symptom history. A blood specimen should be taken as soon as possible, tested, and stored for possible retesting. The flow diagram on this slide provides testing and follow-up recommendations for pregnant women. Additional recommendations for laboratory testing are available in Chapter 22 of the VPD Surveillance Manual. A link to that chapter is found at the bottom of the slide. In settings where pregnant women may be exposed, outbreak control measures should begin as soon as rubella is suspected and should not be postponed until laboratory confirmation of cases. In other high-risk settings, control measures should be implemented as soon as one case of rubella is confirmed in a community. In schools and other educational institutions, exclusion should be considered for all persons who do not have evidence of immunity. Unvaccinated persons who receive MMR vaccine as a part of the outbreak control may be immediately readmitted to school, provided all persons without documentation of immunity have been excluded. In healthcare settings, exposed healthcare personnel without adequate presumptive evidence of immunity should be excluded from duty, beginning 7 days after exposure to rubella and continuing through 23 days after last exposure, regardless of vaccination during control measures.
Thank you, Kelly. At this time, we will now be joined by Paul Gaston-Dewey. Dr. Gaston-Dewey will be discussing rotavirus surveillance. Dr. Gaston-Dewey is an epidemiologist in the Division of Viral Diseases in the National Center for Immunization and Respiratory Diseases at CDC.
Thank you, Dr. Sugarman. I appreciate the opportunity to discuss rotavirus during this training. Rotavirus was the most common cause of severe gastroenteritis in infants and young children before the advent of rotavirus vaccines. The clinical spectrum of rotavirus illness ranges from mild, watery diarrhea of limited duration to severe diarrhea with vomiting and fever that can result in dehydration with shock, electrolyte imbalance, and in very rare occasions for U.S. children, death. Following an incubation period of 1 to 3 days, the illness often begins abruptly. Vomiting often precedes the onset of diarrhea. Severe dehydrating rotavirus infection occurs primarily among children 3 to 35 months of age. Gastrointestinal symptoms generally resolve in 3 to 7 days. Rotaviruses are shed in high concentrations in the stool of infected children and are transmitted primarily by the fecal-oral route, both through close person-to-person contact and through fomites. Rotavirus is highly communicable with an infectious dose of less than 100 virus particles. 2 rotavirus vaccines are currently licensed for use in the United States. RV5, whose brand name is Rotatec, is produced by Merck. It is a live oral human bovine reassortant rotavirus vaccine that was licensed in the US in 2006. The Advisory Committee on Immunization Practices recommends routine vaccination of infants with 3 doses of this vaccine, administered at 2, 4, and 6 months of age. RV1, brand name Rotarix, is produced by GlaxoSmithKline. It was licensed in the US in 2008. This live oral vaccine contains an attenuated monovalent human rotavirus strain. RV1 is recommended to be administered in 2 doses to infants at ages 2 and 4 months. Following the introduction of rotavirus vaccines into the U.S. childhood immunization program, surveillance data have been used and will continue to be needed to document the following. Monitor the impact of vaccination in reducing the morbidity and mortality from rotavirus disease. Evaluate vaccine effectiveness in field use over time. Determine the causes of possible vaccine failure. Monitor possible emerging rotavirus strains. identify population groups that might not be adequately covered by vaccination, and continue to monitor the safety of rotavirus vaccines. Since nearly every unvaccinated child develops rotavirus gastroenteritis by 5 years of age, and confirming a diagnosis of rotavirus requires laboratory testing of fecal specimens, identification of every case of rotavirus is not practical or necessary at this stage of the rotavirus vaccination program. Instead, surveillance efforts at the national level should focus on monitoring trends of severe rotavirus disease, such as rotavirus hospitalizations or emergency department visits. These efforts may also include more intense surveillance at some sentinel sites. In addition to surveillance for severe disease, viral strain surveillance is also essential. In the United States, rotavirus surveillance is conducted in several ways. The new Vaccine Surveillance Network, known as MVSN, conducts active population-based surveillance for rotavirus-associated hospitalizations and emergency room visits among children. MVSN commenced rotavirus surveillance during the 2006 rotavirus season with 3 original sites. The network now includes 7 surveillance sites at medical centers located in Tennessee, New York, Ohio, Texas, Kansas, Washington, and Pennsylvania. Acute gastroenteritis cases are identified and additional epidemiological and clinical information is collected from parental interviews and medical chart reviews. Stool specimens are tested for rotavirus antigen at each surveillance site, and CDC laboratories confirm and type all positive specimens. Analyses are conducted to estimate disease burden, vaccine impacts, and to assess rotavirus vaccine effectiveness in field use. Laboratory-based sentinel surveillance systems that monitor temporal and geographic patterns of rotavirus include the National Respiratory and Enteric Virus Surveillance System and the National Rotavirus Strain Surveillance System. Data from national healthcare utilization datasets are also routinely analyzed to detect national trends in rotavirus healthcare encounters. Numerous post-licensure publications documenting rotavirus vaccine impact have consistently demonstrated great declines in the incidence of rotavirus gastroenteritis. Using hospital discharge data from 18 states, which account for 49% of the US population, rates for all-cause gastroenteritis hospitalization for children younger than 5 years of age were calculated. Compared to the median rate of rotavirus gastroenteritis from 2000 to 2006, which is during the pre-vaccine era, the rates for 2007 and 2008 were 16% and 45% lower, respectively. These analyses were among the first findings that showed a dramatic reduction in rotavirus gastroenteritis among US children almost immediately following rotavirus vaccine introduction. Additionally, administrative data from 39 states covering 2007 to 2015 show a 60 to 98% decline in rotavirus-coded hospitalizations for children younger than 5 years of age in the post-vaccine compared with the pre-vaccine era. Post-vaccine reductions were also observed in rotavirus gastroenteritis emergency department visits. Rotavirus vaccines have also been observed to provide indirect protective benefits even among those who have not been vaccinated. Analysis of large hospital discharge databases show a statistically significant lower rate of rotavirus gastroenteritis hospitalization among household members having a vaccinated child. A biennial disease pattern has been observed following rotavirus vaccine introduction, with higher rotavirus incidence during odd years and lower rotavirus incidence in even years. In more recent years, this biennial pattern seems to be diminishing with higher vaccine coverage, although still fewer than 80% of eligible US children receive a rotavirus vaccine. At this stage of the rotavirus vaccination program, case investigations are usually not warranted. However, outbreaks of rotavirus among childcare or school settings could indicate where gaps in vaccine coverage occur, and could be an indication of waning immunity in older children. Because aerial outbreaks can be caused by many pathogens, a laboratory investigation for the causative agent that includes viral, bacterial, and parasitic agents should be considered for gastroenteritis cases seeking medical attention. As the U.S. rotavirus vaccination program evolves, rotavirus vaccine coverage increases, and rotavirus control among U.S. children continues to improve, our surveillance will continue to adapt to new epidemiologic and surveillance trends.
Thank you, Dr. Gastronuti. Varicella will be presented by Patricia Castro-Roman. Ms. Castro-Roman is an epidemiologist and surveillance officer in the Division of Viral Diseases in the National Center for Immunization and Respiratory Diseases at CDC.
Thank you, Dr. Sugarman. I look forward to discussing varicella. Varicella is a febrile rash illness caused by a primary infection with the varicella zoster virus. It is characterized by an itchy, maculopapular, and vesicular rash, usually with 250 to 500 skin lesions, and simultaneous presence of skin lesions in various stages of evolution. Usually, it is a mild disease, but complications can occur at any age. Severity is increased among immunocompromised persons, pregnant women, children younger than 1 year of age, and adults. Rarely, these complications may result in death, including in previously healthy persons. Varicella can occur in vaccinated persons. This is termed breakthrough varicella. Compared to varicella in unvaccinated persons, breakthrough varicella has a milder, atypical presentation. Breakthrough varicella usually presents with fewer than 50 skin lesions, few or no vesicles, low or no fever, and fewer days of illness compared with unvaccinated cases. Diagnosing breakthrough varicella is important because these cases are infectious. However, given its modified presentation, it can be challenging for providers to recognize it clinically. Before varicella vaccination was recommended in the United States, about 4 million varicella cases, more than 10,000 hospitalizations, and about 100 to 150 deaths occur annually. Given this burden, varicella vaccination was implemented in the U.S. in 1995, initially as a one-dose program. Since 2007, 2 vaccine doses are recommended routinely at ages 12 to 15 months and 4 to 6 years. The varicella program implementation was highly successful. Among young children, coverage with 1 or more doses reached 89% by the end of the first dose program, and ranged between 90 to 93% since 2007. The uptake of the second dose was rapid, and after the 2007 recommendation, the vaccine coverage among teens has been 90 to 91% since 2018. The U.S. varicella vaccination program led to a 97% reduction in varicella incidence, with declines in all age groups. Severe varicella outcomes, such as hospitalizations and deaths, declined by 90%. The greatest decline for both was among persons younger than 20 years of age born during the varicella vaccination program. In this age group, varicella hospitalization has become a rare event, and deaths have been practically eliminated in the United States. Varicella outbreak sites and duration have also declined. Size has declined from a median of 15 cases to a median of 7 cases per outbreak. Duration has declined from a median of 45 days to a median of 30 days. Consistent with the aim of the second dose introduction, the number of outbreaks declined 82% during the 2-dose program. Currently, fewer than 150,000 varicella cases, 1,400 hospitalizations, and 30 deaths per year are occurring. Laboratory confirmation of varicella is increasingly important given the modified presentation of varicella in vaccinated persons and unfamiliarity of providers and public with the presentation of varicella. Virologic methods are recommended to confirm varicella, and real-time PCR is the diagnostic method of choice. Specimens include vesicular fluid or scabs from skin lesions. In the absence of vesicles or scabs, scrapings of maculopapular lesions can be collected for testing. Serologic testing, including IgM, is not useful or recommended for confirmation of acute disease. Continuing improved varicella surveillance is critical to monitor the varicella vaccination program and to further guide prevention efforts. One key objective includes monitoring the impact of the vaccination program. And we need nationwide data given the more than 97% decline in incidence. Additional objectives include characterize and understand changes in the burden of disease, including severe disease, characterize population requiring additional disease control measures, detect and respond to outbreaks, and evaluate vaccine effectiveness. With the reduction in the number of varicella cases, jurisdictions have increased opportunities for improving varicella surveillance. As of 2024, 40 states and DC are conducting varicella case-based surveillance. Also, 65 jurisdictions are funded through the Epidemiology and Laboratory Capacity, or ELC, cooperative agreement to conduct varicella outbreak surveillance as part of prioritized activities to improve surveillance for vaccine-preventable diseases. To improve the completeness of data available to monitor severe varicella, reporting of varicella hospitalizations is included as a voluntary ELC activity for about 27 jurisdictions. Next, I'll present several updates for varicella surveillance during 2024. An updated varicella case definition went into effect in January 2024 and can be found on both the CDC and CST web pages. There were several reasons why the 2009 varicella case definition was updated. As mentioned previously, with the large declines in varicella incidence, there was a need to account for the current varicella epidemiology and clinical presentation of varicella. The 2009 varicella case definition likely picked up non-varicella cases, so there was a need to increase the specificity of the case definition. Herpes zoster, or shingles, was not included as a source of exposure in the 2009 position statement. Finally, jurisdictions asked for guidance about the role and utility of varicella zoster virus, or VZV, IgM testing, which was not previously addressed. To summarize the main changes, the new case definition and classification increases the specificity of confirmed cases by including only cases that are laboratory confirmed or have confirmatory epi-linkage evidence. It also addresses classification of varicella cases with generalized maculopapular rash, but without any vesicles, as well as for varicella cases with only a provided diagnosis and no rash description. Includes herpes zoster as a source of exposure. Lastly, it clarifies the role of IgM in case ascertainment and case classification. CDC created an info to aid in classification of probable and confirmed varicella cases using the 2024 varicella case definition and classification. The varicella outbreak definition was also updated in 2024. Varicella outbreaks were previously defined as 5 or more cases. The definition was updated to define varicella outbreaks as 3 or more cases. Several key variables help us with monitoring the impact of the vaccination program. Some are new in accordance with the new case definition. These key variables are listed on the slide and include age, vaccination status, rash description, outcomes such as hospitalizations and deaths, and laboratory and epidemiologic data in terms of transmission and association with outbreaks. They are also described in the varicella chapter of the VPD surveillance manual. And lastly, given the emphasis on lab confirmation, CDC created a tool with guidance for appropriate tests, specimens, and helpful visuals to help providers order appropriate testing for confirming acute disease and screening for immunity. Thank you. I appreciate the opportunity to discuss varicella.
Thank you, Patricia. At this time, we will discuss acute flaccid myelitis and polio, presented by Adriana Lopez. Ms. Lopez is an epidemiologist and surveillance officer in the Division of Viral Diseases in the National Center for Immunization and Respiratory Diseases at CDC.
Thank you, Dr. Sugarman.
Since September 2014, CDC has been investigating reports of patients across the United States who have a neurologic illness called acute flaccid myelitis, or AFM. In this segment, I will discuss what we have learned from our investigation of these patients, and I'll share our guidance for AFM specimen collection and laboratory testing conducted at CDC, and also provide updates on the case definition for polio. We know that AFM is a rare condition that affects the nervous system, specifically the spinal cord. It causes sudden weakness or loss of muscle tone and reflexes in the arms or legs. In addition, some patients may have facial droop or weakness, difficulty moving the eyes, droopy eyes, or difficulty with swallowing or slurred speech. This condition specifically involves the neurons or gray matter of the spinal cord. Conditions like AFM can have many different causes, including infections with viruses like poliovirus or West Nile virus, and non-infectious conditions that lead to neurological disorders. For surveillance purposes, the Council of State and Territorial Epidemiologists, in conjunction with CDC, has developed surveillance case definitions for AFM. The original definition, developed in 2014, has been modified to better determine occurrence of AFM and add sensitivity to the surveillance system. Of note, a surveillance case definition may differ from a diagnosis from a doctor and should not change treatment or patient care. The National Standardized Case Definition for AFM was first adopted by CSTE in 2015 and last updated in 2021. Patients meeting the reporting to criteria of 1, acute onset of flaccid limb weakness, and 2, magnetic resonance imaging, or MRI, showing a spinal cord lesion in at least some gray matter, should be reported by the clinician to their local and state health department. A confirmed surveillance case of AFM is defined as a patient with onset of acute flaccid limb weakness and an MRI showing a spinal cord lesion with predominant gray matter involvement and spanning one or more vertebral segments. Spinal cord lesions may not be present on initial MRI. Therefore, a negative or normal MRI performed within the first 72 hours after onset of limb weakness does not rule out AFM. Clinicians should report all patients suspected of having AFM to local or state health departments. Health departments should then share information for these patients with CDC using a patient summary form, which is available on CDC's website and can be found by typing CDC AFM data collection form in your search engine. Reports of MRI findings and other clinical information like neurology consult notes and MRI images should accompany the form when sending case surveillance data to CDC. To provide consistency in case classification, review of case information, and assignment of final case classification for all suspected AFM cases is done by a panel of national experts in AFM surveillance after the information has been sent to CDC. CDC has been conducting surveillance for AFM since August 2014. The number of confirmed cases for which CDC has received information is represented by the blue bars on the epi curve. From August 2014 through December 2024, CDC received information for 769 patients who were confirmed with AFM. Since AFM surveillance began, increases in AFM cases have occurred in 3 different years: 2014, 2016, and 2018. Given the biennial pattern, another increase was expected in 2020. However, the COVID-19 pandemic and mitigation measures implemented to combat COVID-19 appeared to impact AFM, and cases have remained at baseline levels since 2019. Epidemiologic and laboratory data accumulated over the last decade indicate that enterovirus D68, or EVD68, is the main driver of the increases in AFM since 2014. However, questions remain about how EVD68 causes AFM and why only some people get AFM. CDC continues to investigate each case of AFM to understand the causes and risk factors. I will now discuss specimen collection and laboratory testing. When a suspect case of AFM is identified, it is important to note that specimens should be collected as early in the course of illness as possible to increase chances of yielding an etiology. In addition to specimen collection for diagnosis and clinical management of the patient at the treating hospital, clinicians should work with their local or state health departments to submit additional patient specimens to CDC. We recommend that clinicians send the following specimens to CDC: cerebrospinal fluid, or CSF, respiratory, serum, and stool. Ideally, the CSF and serum would be collected within 24 hours of each other. In addition, CDC recommends 2 stool samples collected 24 hours apart to rule out the presence of poliovirus. AFM and polio appear clinically similar, and the only way to distinguish between them is through testing stool for the presence of poliovirus. In 2022, a case of polio was identified in New York. This case demonstrated that it is likely that there are periodic importations of poliovirus from other countries into the U.S., and that it is important to test for poliovirus in suspected AFM cases, especially in those who are not vaccinated or under-vaccinated against polio. Detailed information regarding specimen collection for AFM is available on the CDC AFM website, with a clinician-specific resource to help guide you through the paperwork and specimen collection process. We encourage clinicians to continue to be vigilant for patients with neurologic symptoms like those of AFM, and to collect specimens from patients suspected of having AFM as early as possible in the course of illness, preferably on the day of onset of limb weakness. Recommended specimens include CSF, serum, respiratory, and 2 stool specimens collected as soon as possible after onset of limb weakness and separated by 24 hours. CDC continues to collaborate with health departments, hospitals, and academic centers across the country to better understand cases of AFM, including potential causes, risk factors, and how often the illness occurs. Data accumulated over time indicates that enteroviruses, and more specifically EVD68, are responsible for the increases in AFM since 2014. However, no specific risk factors have yet been identified. There are general steps for clinicians that can help protect their patients from certain viruses, such as poliovirus and West Nile virus, which very rarely may lead to conditions like AFM. Recommended steps include making sure that patients are up to date on polio vaccinations and advising patients to use mosquito repellent. In general, good hand hygiene practices will also help reduce the risk for and spread of infections from various pathogens that could potentially cause AFM. Although AFM is not a nationally notifiable condition, it is reportable either explicitly as AFM or as a condition of unusual occurrence in most jurisdictions. Over time, surveillance data have demonstrated a low-level baseline rate of AFM that likely includes a mixture of infections and neuroinflammatory conditions that look like AFM. However, AFM remains a rare condition. We encourage clinicians to be vigilant for patients with neurologic symptoms like those caused by AFM and to report them to the health department. Our understanding of this rare illness will be improved by the continued information gathering from patients with AFM. As mentioned earlier, AFM and polio, or paralytic poliomyelitis, look clinically similar, and the best way to distinguish between the two is to collect stool specimens for testing and detection of poliovirus. To help better differentiate between AFM and paralytic poliomyelitis, CSTE updated the case definition for paralytic poliomyelitis in 2023 to add a laboratory component. A confirmed case is now defined as acute onset of flaccid paralysis with decreased or absent tendon reflexes in the affected limbs and either poliovirus detected by sequencing of the capsid region of the genome by the CDC poliovirus laboratory, or poliovirus identified in an appropriate clinical specimen of which stool is preferred, using a properly validated assay, and where the specimen is not available for sequencing by the CDC poliovirus laboratory. Therefore, an AFM case that is positive for poliovirus would be classified as a confirmed case of polio and not AFM. Although polio in the U.S. is expected to be rare, testing for poliovirus among AFM patients is important as long as poliovirus is circulating in other parts of the world.
Thank you, Adriana. This concludes the AFM section of the training. We will now be joined remotely by Sandy Rausch, who is the Associate Director for Surveillance in the National Center for Immunization and Respiratory Diseases at CDC.
Thank you, Dr. Sugarman. At this point, we'll provide an overview of epidemiology and laboratory-related surveillance activities at the local, state, and federal levels. We'll also consider the needs for surveillance in the context of the status of the disease control program. This information is applicable to both viral diseases, which were discussed today, and bacterial diseases, which will be discussed in another session. As a result of effective immunization programs, diseases that were once major causes of death and morbidity in this country now occur so infrequently that many people in the U.S. have never seen a case of a vaccine-preventable disease. Our challenge now is to identify the factors that allow the remaining cases to occur. We also want to extend our success with the elimination of endemic measles, rubella, and polio to other diseases like pertussis, mumps, and varicella. In the United States, requirements for reporting diseases and conditions of public health concern are mandated by state laws or regulations, and the list of reportable diseases and conditions in each state differs. State and local public health officials rely on healthcare providers, laboratories, and other public health personnel to report the occurrence of diseases and conditions of public health concern to state and local health departments. CDC and the Council of State and Territorial Epidemiologists have established a policy under which states and certain other jurisdiction health departments then send notification of cases to CDC through the National Notifiable Diseases Surveillance System, or NNDSS. At the local level, we need surveillance information rapidly so that disease control activities can be started. An example is providing antibiotic prophylaxis for contacts of a person with pertussis, or vaccinating susceptible persons when outbreaks occur. Before cases of any disease can be counted, we must first define what it is we are counting. This critical component of public health surveillance requires standardized national case definitions. These case definitions can be found in the Manual for the Surveillance of Vaccine-Preventable Diseases. The link to the surveillance manual is provided here. CDC also maintains a webpage that contains the public health case definitions for all conditions under national public health surveillance, including the vaccine-preventable diseases. This is also a very useful webpage, and the link to this page is provided here. For each vaccine-preventable disease, there are specific critical data that must be collected in order to plan and implement appropriate public health action. For each case, we need demographic information and relevant clinical data, vaccination history, and laboratory test results. This is the information needed to classify cases, and it is critical for the evaluation of cases of vaccine-preventable disease. In addition to gathering information about the case, we need to try to identify the people to whom that person may have transmitted the infection. And we need to identify the source from which that person was infected. Also, we need to find out whether the case is linked to an outbreak or it is an isolated sporadic case. We cannot assume that no other cases have occurred just because no other cases have yet been reported. At the state level, surveillance data for vaccine-preventable diseases is needed to evaluate the effectiveness of disease control programs. When there is a case of a vaccine-preventable disease in a person for whom there is a vaccination recommendation, it should serve as a warning to public health officials. There may be other susceptible individuals who should have been vaccinated but were not, or there may have been waning immunity in a vaccinated individual. Important questions for public health include, was the person vaccinated? And if not, why not? Were there missed opportunities to vaccinate? Is there a more widespread problem? In addition to the evaluation of disease control programs, there are other needs for surveillance data. At the national level, we use surveillance data to formulate national immunization policy and also to evaluate the effectiveness of immunization programs. We also rely on surveillance data to evaluate the effectiveness of the vaccines themselves and to document the impact of national immunization efforts. This is especially important with the newer vaccines. Changes in vaccine schedules also require careful surveillance and evaluation. The data that's needed from public health disease surveillance systems depends on where we are in our disease control program. What we need early in the program, or when there are large numbers of cases, is quite different than what we need when the program is very far along with fewer cases. Of course, we also need to ensure adequate surveillance for vaccine adverse events for any vaccine currently in use, regardless of the stage of disease control. Before a vaccine is available for routine use, the public health surveillance information we need is pretty simple. We need to have a baseline of reported disease. Complete reporting is not essential, but we do need year-to-year consistency. We need national data to represent the epidemiology of the disease prior to the availability of the vaccine. But during this phase, aggregate reporting of case counts is usually sufficient. However, when a new vaccine is recommended for routine use and disease remains very common, our goal shifts to monitoring the impact of the national vaccination efforts. The public health surveillance system will need to provide information such as the person's vaccine history and may also include specific epidemiologic and laboratory data. When we have good disease control, such as what we have now for Haemophilus influenzae type B and many other vaccine-preventable diseases, we need enhanced surveillance so we can document vaccine impact, evaluate effectiveness, and monitor progress toward disease elimination. We can use this information to figure out why the cases that remain continue to occur. With good disease control, we need detailed information from individual case investigations, including vaccination status and laboratory confirmation. We also need highly specific public health case definitions because we really want to make sure that the cases we're counting are real cases of the disease. This is the phase when every case counts. Then, when disease incidence is extremely low and we're striving for elimination, the quality and completeness of reporting and the quality and completeness of individual case investigations becomes even more important. At this point, the organism may no longer even be circulating, and we can use molecular typing methods to help document that. Surveillance for vaccine-preventable diseases, or VPDs, requires the close collaboration of clinicians, public health professionals, laboratorians, and other partners. Public health surveillance relies on both clinical and laboratory reports for VPDs. Therefore, appropriate specimen collection, transport, and laboratory testing are all essential. In the VPD surveillance manual, each disease-specific chapter, that's starting with chapter 1, diphtheria, all the way through Chapter 17, varicella, provides a quick reference summary of the laboratory information that would support public health surveillance for that disease. In addition, Chapter 22 of the VPD Surveillance Manual provides even more detailed guidelines regarding vaccine-preventable disease specimen collection and testing. The chapter covers such topics as confirmatory testing, specimen collection, and interpretation of laboratory results. Healthcare providers should contact their local or state public health department for assistance regarding appropriate testing for vaccine-preventable diseases and conditions of public health importance to support public health within their clinical practice. In addition to the guidelines presented in this course, local and state health department personnel can provide jurisdiction-specific guidance related to reporting requirements, specimen collection, and transport. In summary, public health surveillance activities must be designed to fit the public health need. We need baseline data for diseases for which a new vaccine is available, but we need detailed individual case investigations when we have achieved higher levels of disease control through vaccination programs.
Thank you, Sandy. This concludes the section of the training. I want to provide a reminder of a few surveillance-related resources that are available. First, the Manual for Surveillance of Vaccine-Preventable Diseases, which includes chapters that provide a quick reference for information that would support public health surveillance for VPDs. It's available at the CDC website at the link shown here on the slide. Secondly, the VPD reference centers are those 4 public health laboratories that were mentioned earlier. The information about the reference centers can be found on the web address shown on this slide. Third, the link to the NNDSS webpage that contains the public health case definitions for all infectious conditions under National Public Health Surveillance is included on this slide as well. Additionally, there is a video available that shows the proper technique for collection of a buccal swab for mumps. The web addresses for the previously mentioned CDC specimen submission form, submission collection and shipping information for AFM, and CDC varicella laboratory are also here on this slide. We certainly hope that you find these resources helpful. In support of improving patient care, the Centers for Disease Control and Prevention is jointly accredited by the Accreditation Council for Continuing Medical Education, ACCME, the Accreditation Council for Pharmacy Education, ACPE, and the American Nurses Credentialing Center, ANCC, to provide continuing education for the healthcare team. The specifics regarding continuing education accreditation for this session are presented on this slide. For this session, you can see there are 1.5 CME credits available, 1.5 CNE credits, 0.2 CEU credits, and 2 CPH credits available. For those seeking education credits, we have the following instructions. To receive continuing education credits for this session, activity number WD-4893-012855-2025 CDC Training for Viral Vaccine-Preventable Disease Surveillance. 1. Pass the post-test assessment at 75%. Complete the evaluation, and visit Your Learning to access your certificates and transcript. At this time, we have a few minutes to discuss some questions that we have received related to viral vaccine-preventable disease surveillance. I'm rejoined by Dr. Oliver and Ms. Rains to review some questions related to mumps and rubella. Our first question is related to mumps. Dr. Oliver, what tests are most important to perform to diagnose mumps?
Thank you for the question, Dr. Sugarman. PCR is the preferred test type to confirm mumps infection, and buccal swabs are the preferred specimen. Specimens should ideally be collected within 3 days of parotitis onset, but can be tested up to 10 days after parotitis onset. If it's been more than 3 days since the parotitis onset, a serum specimen for IgM testing is also recommended.
Thank you. Ms. Rains, should IgM testing be used for assessing rubella immunity?
Yeah, that's a good question. No, IgM should not be used for assessing rubella immunity. Rubella immunity should only be assessed based on IgG testing. In the US, rubella immunity is routinely assessed in pregnant women and for certain individuals with occupational requirements. Although rubella immunity should only be assessed based on IgG testing alone, some commercial labs provide both IgG and IgM results when immunity testing is requested. Consequently, false positive IgM results are sometimes reported, causing burdensome public health investigations and inaccurate classification of rubella in situations where no clinical or epidemiologic suspicion exists.
I have one final question for you, Ms. Rains. Should reflex laboratory testing for rubella be conducted after a negative measles result?
That's a good question. Yes, it is important to consider rubella in the differential diagnosis of patients under evaluation for other febrile rash illnesses, including measles, parvovirus, dengue, Kawasaki's disease, and scarlet fever. Anytime rubella is suspected, specimens should be collected for both molecular and serologic testing at the time of the initial investigation.
I will now review some questions we received regarding measles. The first question is, why is measles incidence higher in 2024 compared to recent years? Overall, measles risk in the United States is determined primarily by two factors: measles immunity in the US population and the global measles situation. As with most years, the majority of cases in 2024 occurred in people who were unvaccinated or had unknown vaccination history. We did not see a rise in cases among people with documentation of vaccination that would make us concerned about changes in our vaccine efficacy. And the second question received is, if a jurisdiction is trying to determine the immune status of a contact, is there a time frame after exposure when an IgG test needs to be performed to be reliable? CDC recently added information about this to our update for the measles surveillance chapter in the VPD surveillance manual. Overall, for people who do not have pre-existing immunity to measles, IgG is not expected to be present in people who go on to develop measles until after rash onset. Therefore, presence of IgG at any point up to rash onset is evidence of pre-existing immunity. If we draw this line back to measles contacts who are being evaluated after exposure, but who do not have symptoms suggestive of measles, this means that any detection of IgG after exposure is evidence of pre-existing immunity, either due to prior measles infection or measles vaccination. This means that any asymptomatic contact who has detectable IgG in a serum sample, regardless of how long it is after their contact with a measles case, has evidence of pre-existing immunity. This concludes the questions related to measles. And thank you all for attending the viral disease session of the 2025 CDC Training for Viral Vaccine-Preventable Disease Surveillance. We hope that you find this information helpful. We will adjourn at this time.